welcome. This is the first of our March Birth Equity webinar series on empowering families. We will have a Q&A section at the end of the webinar, so we ask that if you have any questions, you just drop them in the chat and we will go through as many as we can at the end of the webinar. Today, our webinar is led by Dr. Carolyn Rogers. I'll give you a little background on her. Dr. Rogers is the chair of public health program at Chicago State University. She's an active leader in various public health and community organizations. She serves on the DEI board of Illinois Charitable Clinics, the Chicago Community West Music Center, and the National Commission of Health Education Credentialing. With a PhD in public health, she specializes in epidemiology and multiple advanced degrees in health sciences. She is also a certified public group personal trainer, youth exercise specialist, and is a co-founder of the American Heritage Youth Foundation. She focuses on community-based interventions, research, grant writing, and data analysis. I will now turn it over to you, Dr. Rogers.
Thank you so much for that excellent introduction. Today, I'm actually going to cover the topic, understanding and addressing implicit bias in maternal health care. This is a topic that is near and dear to my heart because I've also had my own experiences with implicit bias in maternal health care. And so today, I just want to provide an understanding for individuals and also practitioners to see how women are affected, how it affects our outcomes, and also things we can do to mitigate many of these issues. So for today's agenda, I'm going to define implicit bias. We're going to discuss the impact of implicit bias on maternal health care. I'm going to describe how to recognize implicit bias in maternal health care, identify the best practices to address implicit bias in maternal health care, and then a discussion and a call to action for practitioners and individuals who are interested in this topic. So one of the things that I wanted to talk about is provide a brief introduction to implicit bias and also provide a little bit of information as to how it affects us. So there's some empirical data that I do have and some statistics that I provide when I'm talking about this topic. So in terms of maternal or mortality disparities by race, a lot of this data that I'm going to present comes from the Centers for Disease Control and Prevention. So in terms of Black women in the United States, we are 3 to 4 times more likely to die from pregnancy-related causes than white women. Black women, pregnancy-related mortality ratio, which we call PRMR, is 55.3 deaths per 1,000 live births. For white women, their PRMR is 19.1 deaths per 100,000 live births. And so in epidemiology, anytime you see us represent an entire population of 100,000, it gives you an idea of how many people it represents per a 100,000 population. And as you can see, there is quite a difference in the pregnancy-related mortality ratio for Black women when compared to white women. The role of implicit bias in pain management and diagnosis. So there was a study published in the Proceedings of the National Academy of Science, and this was actually done in 2016. They found that 50% of medical students and residents believed that Black patients feel less pain than white patients. And even in 2025, this is still relevant. So these are contributing to disparities in pain, treatment, and management. And that was a study done by Hoffman, Trollwater, and Oliver, done in 2016. When it comes to patient-reported experiences of disrespect and dismissal, in listening to the Mothers 3 survey, 1 in 5 Black women reported experiencing poor treatment from hospital staff due to their race, ethnicity, language, or culture during maternity care.
Excuse me.
Yes.
Sorry, Dr. Rogers, your screen is not sharing.
Oh, okay. So are we stuck on the initial screen?
Yes.
Okay, let me see if I can fix that. Let's see here. Is it showing now?
Yes.
Okay, excellent. Where was I? Okay, so in terms of the role, excuse me, of implicit bias, oh, I already went over that one. In pain management, we see that 50% of medical students and residents believe that Black patients feel less pain. So that's still relevant today. Went over patient reported experiences of disrespect and dismissal. So in this survey, they surveyed African American women um, who were mothers, and it says that 1 in 5 Black women reported experiencing poor treatment from hospital staff due to their race, ethnicity, language, culture during maternity care. The other statistic that I wanted to talk about is implicit bias correlates with unequal treatment. Many people may not realize that, but there was a systematic review that was published by the American Journal of Public Health in 2015, and they found that implicit biases among healthcare professionals are pervasive and linked to poor patient provider communication, lower quality of care for marginalized racial ethnic groups, so on and so forth. So implicit bias does exist, it's prevalent, and it's something that needs to be talked about. Are you able to see the next slide?
Yes.
Excellent. All right, so when we talk about implicit bias, the first thing I want to do is define it because many people may not know what implicit bias is in comparison to explicit bias. So the first thing I'm going to talk about is what explicit bias is. Explicit bias is conscious and intentional attitudes, beliefs, or preferences towards a person or a specific group. And so that means the person knows what they're doing. When we talk about implicit bias and what makes it so important is that it's an unconscious attitude or stereotype that affects understanding, decisions, and actions. And the people that are often participating in this are unaware of these biases that they hold. And so they may not even know that they're doing certain things to certain groups of individuals. So the first thing that they need to gain is awareness. And that awareness will speak to the unconscious and automatic bias that has been occurring. So people are typically unaware of their bias. That's one of the things that we found in research. And so some of the behavior impacts that we often see are influences, and these are actions without intention that are often in subtle and unrecognizable ways. And unfortunately, many minorities have been on the receiving end of this kind of behavior. So an example, excuse me, would be of this unconscious or implicit bias would be a provider unintentionally dismissing a Black woman's report of pain due to unconscious stereotypes. Whereas explicit bias, again, the definition is conscious attitudes and beliefs a person holds about a group. So these, again, are biases that are intentional and openly expressed. And the awareness of it is conscious, they are aware, and it's deliberate. And so people are aware of their biases and they often act on it intentionally. So this, again, is explicit bias. Now, what is the behavioral impact? It directly influences their behavior in clear and overt ways, not covert, but it's overt, it's outwardly being done. And so, an example of explicit bias is a healthcare provider openly believing one racial group is less deserving of care and acting accordingly. And oftentimes we see this in the substance use community as well. For people who use substances, they often get mistreated as well. And so that would be explicit bias. So I just wanted to make sure that we're all on the same page in terms of defining these things and how it impacts what we do as providers. Can you see? Uh,
Yes.
okay, so let me go here. All right. So the next slide is how implicit and bias impacts our health outcomes. And that's a very, did my screen just switch again? Let me go back.
Yes.
I think it's switching on. Okay. Yeah. So how implicit and bias impacts our health outcomes. So some of the disparities that are due to increased decreases and mortality among certain ethnic groups include implicit bias. So again, that refers to unconscious stereotypes and attitudes that healthcare providers may hold, even if they believe in fairness and equality. And I know that sounds strange, but Again, it's unconscious because they don't know that they're doing it. So these biases can negatively influence our clinical decisions, communication, and of course, patient trust. So it's leading to worse health outcomes, to put it shortly, particularly for these marginalized groups that I'm mentioning today. So one of the things is delayed or inadequate care that people are often receiving. The studies show that Black women are 3 to 4 times more likely to die, again, from pregnancy-related causes than white women. And this is regardless of income or educational level. And again, this data is coming from the Centers for Disease Prevention and Control. The second thing is pain management disparities. A landmark study found that half of medical trainees believed myths that Black people have thicker skin or feel less pain. That is still relevant today. So, as a result, you have Black patients who are often receiving less adequate pain management than white patients. Okay. There's a communication gap and disrespect. So there's 21% of Black women who reported that that they received poor treatment during maternity care due to their race or ethnicity. And again, this is perpetual. It leads to mistrust, lower patient engagement, and missed signs of complications. There was a survey, and this was from the survey, Listening to Mothers 3 survey that was done in 2013. The other thing is disparities in maternal morbidity. So, Black women are twice as likely to experience severe maternal mortality, which are life threatening complications during childbirth, compared to white women. And again, this is current data from the Centers for Disease Control done in 2022. The fifth thing is implicit bias. It can predict unequal treatment. So there was a systematic review of healthcare providers that was found that implicit racial bias was associated with poor patient provider communication, lower patient satisfaction, and reduced treatment adherence. Okay, so again, this is how implicit and bias impacts our health outcomes. Okay, I'm at the next screen. Can you see it?
Yes.
Okay, so the next thing I'm going to talk about is the impact of implicit bias on our healthcare system, and I'm also going to provide you some statistics and more. So in terms of the health disparities, a lot of this information you're going to hear again and again because I'm trying to drive it home, is that there are health disparities, it increases. That's one of the impacts. And we know that implicit bias does contribute to racial and ethnic disparities in healthcare. So what are those disparities? It's a disparity in our access, a disparity in quality of care, and a negative disparity in the outcomes that are provided. So, an example again would be Black women are 3 times more likely to die from pregnancy related causes than white women. And again, that is something prevalent to continue to think about 3 to 4 times more likely. Again, there's unequal treatment decisions. Providers may unintentionally underdiagnose or undertreat patients from marginalized groups. One example of this is that studies have shown that Black patients are less likely, again, to receive adequate pain management. When I was working in the field of addictions, we saw that often. And a lot of it was people making assumptions for individuals who they thought were receiving treatment, and for individuals who were receiving treatment. In other words, just because they were Black, they assumed that they might overutilize these pain medications. And these were individuals who had not had experiences with substance use. And then we see it heavily in individuals who have had instances with substance use. So it doesn't matter if you were not a substance abuser. We still see that there is adequate pain management for African Americans. Reduce patient trust and satisfaction. So patients who perceive bias are less likely to trust their providers. And then they're less likely to follow their treatment plans. And they're also less likely to seek care in the future because they understand and can see when they feel someone does not have their best interests in mind, or that they're being prejudged because of their race, ethnicity, or background. There's also poor communication, and feelings of that they are being dismissed, disrespected. And again, you find that there's reduced patient engagement. In terms of increased morbidity and mortality, that often happens when there are delays in the diagnosis. We've seen that over and over again in the clinical setting. Things that could have been prevented in terms of morbidity and mortality, it was because of the delays in the diagnosis that the patient ended up either getting a disease or dying. Inappropriate treatment plans, and inadequate follow-up. So those are some of the things that we need to take a look at and continue to monitor. In terms of statistics on maternal health disparities, we tend to see Black Indigenous women, again, experiencing these 2 to 3 times higher mortality rates. Now, with that, you know, we think about education and education being the disparities. But what we're seeing is that the disparity persists across all income and education level. So with Black women that have higher education and income, they still face significantly worse maternal outcomes than white women with lower education and income. So an example of that would be, excuse me, a college educated Black woman is more likely to die from pregnancy related causes than a white woman without a high school diploma. And this, again, is data that comes from the Centers for Disease Control. The latest statistic is from 2019 and still prevalent today. Number two is the implicit bias. It operates independently of socioeconomic status. So that's important to note because socioeconomic status, the implicit bias, again, it's unconscious and it affects the clinical decision making, even when providers know that a patient's even when providers know what a patient's socioeconomic status is. So there's some studies that have shown that healthcare providers unintentionally hold negative stereotypes about Black patients, such as assumptions about pain tolerance or compliance, regardless of their socioeconomic status. And this was done by researchers Hoffman and team in 2016. There's also structural racism and discrimination that have lasting effects on individuals. So what you often see is chronic exposure to racism that's related to stress, also called weathering. And this leads to premature aging and worsened health outcomes, which cannot be mitigated by socioeconomic status alone. So this stress, it affects a person's immune system, their cardiovascular system, and their endocrine systems, which increases risk during pregnancy and childbirth. And again, that was a study that was done by Geronimus in 2006, and it's still prevalent today. The other thing that I'm going to talk about is trust, communication issues. They're not fixed by a person's socioeconomic status. And you would think that it would be with a higher education. But what we've seen is that it hasn't. So higher income or highly educated women of color often report feeling disrespected, ignored, or dismissed by their providers. These interpersonal experiences often result from implicit bias, which isn't reduced, again, by the patient's socioeconomic advantage. The fifth thing I'm going to discuss is the implicit bias influences that provider behavior has more than patient background. So what that means is that if there's an implicit bias that influences how providers interpret symptoms for these patients, whether they believe a patient and what treatment they offer, regardless of the patient's wealth or status. So an example of that would be a Black woman, that Black women are less likely to receive necessary interventions or have their concerns taken seriously, no matter their socioeconomic status. And so again, these are all important facts that need to be considered. So, what does the research on implicit bias in healthcare say? Well, again, we are showing that the studies that impact racial biases affect pain management, which is a big part when it comes to childbirth. Those treatment recommendations, some recommendations may not be put forth. And then, of course, the patient interaction. If patients are not feeling like they trust their providers, then there's going to be less interaction between the patient and the provider. And again, providers may underestimate pain levels of Black patients. And I want to hammer that home because that is very important, is very relevant, and it's thick throughout the research. So, in terms of personal stories, one of the celebrities that I wanted to talk about is Serena Williams. Many of you know the story about Serena having complications, but I wanted to go further into her story to explain what actually happened. So, after Serena delivered her daughter Olympia by C section, this was in 2017, she experienced some serious complications. She had a history of pulmonary embolisms, which are blood clots in the lung, and was at a higher risk for blood clots after surgery. So the day after she gave birth, Serena felt short of breath and immediately suspected another pulmonary embolism. Okay, so that's important to note. Knowing her own medical history, she alerted the nurses and requested a CT scan, and she also requested blood thinners. But instead of being taken seriously, the medical team initially dismissed her concerns, attributing her symptoms to something less serious. They thought she might be confused from pain medication. Serena had to insist repeatedly before they performed the appropriate diagnostic test. And what did they find? The CT scan confirmed that she had multiple blood clots in her lungs. Because of the delay, additional complications followed, and she had to have an emergency procedure to prevent the clots from reaching her lungs. She then experienced a hematoma in her abdomen, which is blood pooling from blood thinners, requiring her to have further surgery. She was confined to bed for 6 weeks and faced a long recovery. So, how this reflects implicit bias, despite her medical knowledge, her status, because everybody knows Serena, she is a celebrity and a tennis star, and her clear articulation, her symptoms were initially dismissed. So, this is a textbook example of implicit bias where the healthcare providers underestimated or discounted the concerns of a Black woman. Her case demonstrates that wealth, fame, education did not protect Black women from the effects of bias in healthcare settings. So, Serena Williams' experience, it highlights the importance of us listening to patients, especially those with a history of health complications. It also highlights how implicit bias can delay diagnosis and treatment that increases the risk of life-threatening complications. And it also highlights that Black women are not immune to being disbelieved or ignored in healthcare, regardless of their socioeconomic status. And so I wanted to just, give a review of some of these real life cases in maternity health advocacy groups. There's a lot more stories that you can review in many of those groups, but I also wanted to share my own story because I also received implicit bias. And this was with my second pregnancy, even though I did experience it with my first pregnancy too, and with all of the degrees that I have in my socioeconomic status. One of the complaints that I had was that my mucus plug came out and I was pregnant with twins. I went in to let the doctors know. They initially checked me out. I was 33 weeks. And I explained to them that I thought that I was going into labor. They initially dismissed my concerns, so I got dressed and they were sending me home. I got all the way out the door. I guess someone thought or had the wherewithal to call the head OB-GYN, which was actually my doctor, and he told them to go and get me that I was a high risk case. And might I add, he was also a minority himself. So I was already outside of the hospital dressed on my way home. They ran to get me to tell me to come back in. And so that's exactly what I did. And I ended up the very next day waking up to bleeding. They put me in a room that was on the second floor, which was a postpartum room for women who had already given birth. But when I woke up, I walked to the restroom and I saw that I was dripping blood, which meant that I was probably at risk for a rupture in my placenta. And so I told the nurse, and the nurse dismissed it and said, "Oh, that's normal." And my mom, who is also a nurse, said that's not normal. She has not had her baby yet. So this is not normal for her. And the nurse dismissed it and walked out. My mom actually had to go into the hallway to find another nurse who saw the drippings of blood on the floor and said, no, that's not nurse. And this happened to be a minority nurse, African American woman. She then got a bed, wheeled me down to the delivery room, and contacted the head OB-GYN, who again was my doctor. He proceeded to have them give me steroid shots so that the baby's lungs could develop as fast as they could before I delivered them, and to prevent any further complications. So that again is one of my, that's my story. And, again, it was through several efforts, and I'm, again, having my mother there with me to also be my voice, that I was able to get the help, because it could have turned into something else that could have been deadly. So again, it doesn't matter a person's socioeconomic status. Implicit bias is real, and it could happen to anyone. So the next thing I want to talk about is recognizing implicit bias in maternal health care. There are certain patterns of unequal treatment that we need to be aware of. And if you notice, if certain groups are consistently receiving less attention or fewer resources of different recommendations, then that right there is the first red flag. The second one is to review the patient feedback. Every time we go into a clinical setting, there's always a survey, that can be done. But then there's also in-person interviews, because you can tell your provider right away. So if providers are reviewing patient feedback, it is important to pay attention to the reports of patients feeling ignored, dismissed, or disrespected, especially among marginalized groups, because if there is smoke, there's likely fire. Disparities in outcomes, that's another red flag. Why are there outcomes? That should be the next question that comes next. So you need to analyze data for those trends that are showing poor outcomes or satisfaction ratings among specific populations, because again, where there's smoke, there's likely fire. Then there's the self-reflection. Providers can assess their own unconscious biases through tools like the implicit association test. So, I welcome all providers to take the implicit association test, because it's good for us to know our own weaknesses. If you don't know your own weaknesses, then you don't know what needs to be strengthened. So the first step is to take the test, implicit association test, to see if you have any unconscious biasness. And that is one way that we could also improve those health outcomes and eliminate implicit bias. The next thing is how bias manifests in medical settings. So some of those disparities include um, increases in mortality among certain ethnic minority groups. One of the things that we need to look at is dismissing or minimizing patient concerns. Some providers may downplay or ignore patient-reported symptoms or concerns, assuming that they're exaggerating or misunderstanding their own health. And really, that is a part of cultural attunement that may need to happen, because we all think that because we speak the same language that we understand each other. No, there are cultural differences that we need to understand. And so that, again, is one of the things that we need to review. So an example of downplaying or ignoring a patient and what they're reporting is Black women pain reports are less likely to be believed or taken seriously. Okay, so again, that is a big reaction that we tend to see from many of those things. Number two is the delayed diagnosis and the treatment. So there can be biases, which again lead to slower recognition of serious health conditions, resulting in delayed or inadequate treatment. So again, example, Black women with preeclampsia may experience delays in diagnosis and intervention, which increases the risk of severe complications. Number three, again, unequal pain management. Certain racial groups, especially Black patients, receive less pain medication or lower doses based on false assumptions that they have a higher pain tolerance. Now, there was a study done that showed that Black patients are 22% less likely than white patients to receive pain medication in the ER. That was a study done by Stanton and his team in 2007. Number four, poor communication and lack of shared decision making. Okay. Providers may fail to explain options, they use dismissive language or dominate the conversation so that you cannot be heard or feel that you are not having the opportunity to speak, making patients feel unheard or disrespected. An example would be patients of color often report that providers don't listen to them or don't offer adequate information. And this was demonstrated in the study about the study done by Hall and his team in 2015. So they're not listening to the patients or the adequate information about treatment, as though the patients have no knowledge. So again, that's something that we need to take a look at. And then number five, negative stereotyping. Providers may unconsciously associate negative stereotypes with certain groups, affecting how they view a patient's behavior, lifestyle, or compliance. There are many providers who will withhold information because they feel that the patient is going to be non-compliant. We've seen that many times. And an example, and again, all of this information is coming from studies, is assuming a patient of color is non-compliant or less educated without having the evidence that information is factual. Number six, less time spent with marginalized patients. Research shows providers may spend less time with patients of color and offer less patient-centered care, contributing to poor outcomes. And this was a study done by Penner and his team. Number seven, underuse of preventative care and screening. People from marginalized groups are less likely to be offered or receive preventative services like mammograms or prenatal screenings. Another thing that we need to take a look at. Sometimes due to provider biases about their abilities to follow up or afford care. So if a provider thinks that you are not going to follow up or afford the care, that is an example of implicit bias. Another one is body language and nonverbal cues. Oftentimes, patients can tell whether or not a provider thinks that what they have to say or who they are is important. Nonverbal signs like lack of eye contact, closed body language, rushed demeanor can make patients feel unwelcome or undervalued. So these behaviors impact patient trust and willingness to return for care. So there are some examples in maternal health care, such as, again, Black women are more likely to report feeling ignored or disrespected during labor and delivery. They are more likely to undergo unconsented medical procedures or not be informed about what's happening during childbirth. And again, that comes out of the survey, Listening to Mothers survey. This one hits heavy for me because during my first pregnancy, the doctor told me that she was going to check me to see how far I was. And really, I should have been sent home because I ended up having a C-section due to failure uh, to progress, which means that my body was not ready to give birth. So instead, the doctor told me she was checking me to see how far dilated I was. And instead of actually checking me, she actually broke my water. So when that happened, it put me at risk for infection. Therefore, since my body did not progress, C-section occurred. That was my first pregnancy. Next slide. There is a Harvard implicit association test that was mentioned earlier. And so this is a way that providers, again, can test their own implicit bias. This project, Implicit, is a nonprofit organization, and it's a research initiative that was created by psychologists from Harvard University, the University of Virginia, and the University of Washington. This was launched to study implicit social cognition. And what they did was they wanted to focus on thoughts and feelings that exist outside of conscious awareness or control. So that again speaks to the question, what is the implicit association test? Well, it's a psychological tool, and is designed to measure implicit attitudes, beliefs, and stereotypes that people may hold, unconsciously, that may unconsciously hold. It explores automatic associations between concepts such as race, gender, evaluations, and whether it's good or bad, and stereotypes. For example, if a person is athletic, if they think a person is athletic or clumsy. So, how does it work? Well, participants would complete a series of timed categorized tasks, and they are also asked to quickly pair words or images. Example, black faces, white faces with good or bad words, okay? And the speed and accuracy of their responses reveal some of the underlying associations. Faster pairings suggest a stronger mental connection. Slower pairings suggest a weaker or conflicting connection. In other words, they had to think about it. Purpose in healthcare and beyond, the IATA helps people become aware of their biases that they may not consciously endorse, but that influence their behavior, including healthcare providers. So, in the healthcare setting, it allows them to recognize these biases and how crucial they are to reducing the disparities, improving patient provider communication, and ensuring equitable care. So, some of the topics that are covered by the Project Implicit test is race, gender and career and science roles, religion, sexual orientation, weight bias, which is a real thing, disability bias, and age bias. So, why is it important to know? Because we need to be aware of our own implicit biases. That is the first step to addressing it by recognizing our own unconscious biases. And so this is how we can continue to help healthcare providers take control of their unconscious biases by becoming conscious to those biases and creating actions to minimize their impact on patient care. So, what is institutional then versus individual bias? And again, that's a real thing. And so, the definition is of individual bias refers to our personal attitudes, our personal beliefs, and our personal actions, whether conscious or unconscious. So, again, this is all representation of a single person that can lead to unequal treatment, or prejudiced behavior towards others. So the types again are explicit bias, which is open and intentional prejudices or discrimination. And we also have implicit bias, which is unconscious attitudes or stereotypes that influences our actions, our decisions without the person realizing it. So examples in healthcare, again, a health care provider is unconsciously, spending less time explaining treatment options to their patients who speak with an accent. A nurse assumes that a low income patient will not comply with post op care, so they don't offer certain resources. Now, in terms of institutional bias, this is what we also call structural or systemic bias. And the definition is it refers to the policies, the practices, the procedures, and the culture that we have within organizations or systems that systematically disadvantage certain groups even if no individual is intentionally discriminating because it's ingrained in the system. So the key points are is that institutional bias is often baked into the system over time and can be hard to detect because it seems normal or neutral. I'm just doing my job. That's a comment that you would often hear to go along with institutional bias. It creates barriers to access, opportunity, and quality care for marginalized populations. So, an example in healthcare would be fewer hospitals in predominantly Black neighborhoods, limiting access to prenatal care or emergency services. And I'll go a step further and say research based hospitals, a lack of research based hospitals in predominantly Black neighborhoods, because we know that research based hospitals tend to have the gold standard of care and the most recent knowledge and current treatment. Okay. So, in terms of clinical guidelines or algorithms that don't account for racial differences, that lead to inaccurate system assessments. So an example of that would be kidney function tests that assume different baselines for Black patients, which would potentially delay a person's treatment. And for kidney situations, that could be deadly, or it could also put a person at risk for needing dialysis treatment. So why does both matter in maternal health care? Well, individual bias can lead to healthcare providers disbelieving or minimizing a mother's symptoms during pregnancy and delivery. Institutional bias, however, results in underfunded hospitals in marginalized communities or limited access to midwives and doulas, which contribute to higher maternal mortality rates. So let's get to the best part of this presentation. What are some of the best practices to address implicit bias in maternal health care? How can we help? So implicit bias training, that's the first thing. If you can get your hands on an implicit bias training, attend one. It implements evidence-based training programs that help healthcare providers recognize and manage their biases. It focuses on empathy building, cultural humility, and patient-centered communication. And it also provides standardized protocols, okay? Use checklists and clinical guidelines to reduce subjective decision-making. Some examples are standardized treatment pathways for managing pain or maternal complications, diversity healthcare workforce, promote hiring and retention of diverse healthcare professionals who reflect the population that's served, greater diversity. This improves cultural understanding and reduce bias. Patient advocacy and support. We need to encourage the use of patient advocates or doulas. They can be our voice, especially for marginalized groups, to help patients navigate care and have their voices heard. And of course, data collection and accountability. I'm big on data collection and accountability. Regularly collect and analyze data on health outcomes by race, ethnicity, and socioeconomic status. Because when you do so, then you're holding organizations accountable for addressing these disparities to improve health equity. And then there's also having culturally competent care. Ensure that healthcare practices are inclusive and respectful of diverse cultural backgrounds. Okay, that's very important. And of course, last but not least, involving community members in co designing these services and policies. Always need to have them at the table because they are stakeholders. Educational and training for healthcare providers. One of the things that I would like to see is more healthcare providers using the Stanford's implicit bias training. Again, that helps you understand implicit bias. It explains what implicit bias is, including how it forms and why it matters in clinical settings. It focuses on unconscious bias, um, how it can negatively impact diagnosis, treatment decisions, and patient outcomes. And then you want to look at how it's particularly for marginalized populations. And then it provides the science behind bias. It reviews neuroscience and social psychology research on how implicit bias operates in the brain. It discusses how stress, time, pressure, and fatigue can exacerbate biased decision making. People tend to act bad when they're, tired or annoyed. Number three, clinical scenario case studies. It provides real life clinical examples showing how implicit bias can affect healthcare delivery. There's also interactive discussions on role playing that help providers recognize bias in action. Number four, it's a strategy for mitigating bias. So the Stanford training tool teaches practical tools to reduce bias, such as perspective taking, where you encourage the provider to actively consider the patient's experience, individuation, focusing on the individual rather than the stereotypes about a group. One person does not represent a group, and a group does not represent one person. Mindful techniques to slow down decision making and increase awareness. Counter stereotypical imaging. This is where you consciously focus on examples that counter stereotypes. And then number five, the commitment to change and accountability. That must be present. So participants create their personal action plans for addressing bias in their practice. So you have to encourage ongoing reflection, peer discussions, and continued learning behind that training. So again, why does it matter in healthcare? Because implicit bias contributes to racial and ethnic disparities in healthcare, particularly in areas like maternal health, pain management, and chronic diseases. So, by addressing the bias, the Stanford program helps reduce many of those disparities in patient care. It allows you to improve trust and enhance those outcomes. And it's evidence based, might I add. So, what is the patient centered care approach? Again, we need to have active listening. We want to make sure that we're validating our patient concerns because, again, that builds trust. And we want to have shared decision making and respectful communication because, again, it's the patient's body. No one knows their body better than the patient. And we should respect and listen to what the patient has to say and make it a shared decision, okay, about what needs to happen next. There are different policy and institutional interventions that we need to look into. And again, that is one of the reasons why I mentioned diversifying the healthcare workforce, because we need to have representation from everybody that's being treated within the facility so that they all can offer their input. And then there's also implementing standard care protocol. When you have standard care protocol, then there are no differences in the treatment protocol that patients will receive based on their race, ethnicity, or gender. There's also community advocacy efforts. So it's important to visit groups like the role of the Black Mamas Matter Alliance and other advocacy groups that could also provide input as to ways that many of the patients would like to see their health care improved. And then you need to encourage patient advocacy and self advocacy in maternal health. So, what is the conclusion to call and to action? Uh, this is just a recap of everything we talk about. Implicit bias, it is unconscious and it has real consequences, as you heard earlier about real people that it's actually affected, including myself. We need to recognize and address it because it leads to better health outcomes and reduces health disparities. And everyone has a role as a healthcare provider, policymaker, and the community. Okay. We need to encourage our healthcare providers to take an implicit bias test. We need to promote advocacy for systematic changes in hospitals where the data shows that implicit bias exists. And we need to support maternal health organizations because they are our friends and can provide us with the information and the knowledge to collaborate to increase patient care. So here are the sources for my presentation and any further reading that anyone would like to do. And I would like to thank you for your time and commitment to this presentation. And I guess now I can take any questions.
Thank you so much, Dr. Rogers. We do have a few questions, so
Okay.
I will read those for you. The first question is, what ongoing education and training opportunities exist for addressing bias in maternal health?
Mhm. Well, one of the things that I already mentioned was the Stanford survey. I think we all need to do an implicit bias test to first see what implicit biases we have, and then the training that was put together by those psychologists to see how we can further improve and eliminate some of the biases, implicit biases that we do have. And then I think we also need to take a look at, again, the hospital policies, any clinical-based policies, to see how we can redraft and include community members to ensure that our policies and our standardized practices are in place to ensure that patient care is equal and equitable for all.
The next question is, how can providers advocate for equitable maternal health care?
Hmm. I think the first thing is to use data. Every time I go to the clinic, I'm always completing a survey and coming in. And when I leave out, there's another survey. And so data is the first line of defense. If we have evidence to show that there is implicit bias or that there are some health inequities um, that can be tracked in data within specific institutional settings, I think that would be the first line of defense to uh, bring up that there is an issue. And I like to use that as a needs assessment. And so by utilizing that as a needs assessment, gives us leverage to then say we need to take a look at, some of the practices that we have and policies to see how we can improve and standardize those policies to eliminate implicit bias.
Thank you. The next question is, what are some best practices for engaging and sharing decision-making with pregnant patients?
I'm sorry, could you repeat that? You broke up a bit.
What are some best practices for engaging and shared decision-making with pregnant patients?
Uh, I think the first thing we need to do is active listening. A lot of times, because we have the knowledge and we are, we're considered the experts. We are quick to speak, and we, tend to listen less. But we have two ears, one mouth, and we need to listen more and only speak once we have assessed what the patient, has described to us. And we need to take everything that they say as face value so that we can analyze um, all of those complaints and issues in a respectable and collaborative way. So I think the first thing is to make sure that we're active listening and that we're also hearing the patient's perspective, repeating things back to make sure that our perspective of what we think we're hearing matches up with what the patient is actually saying. Because sometimes what we think we're hearing is not actually what is being said. That's also a part of cultural competency and cultural attunement. So active listening, ensuring that our perceptions match what the patient is actually saying, and then collaborating with the patient to identify the best care, and also looking again at standard protocol to make sure that the standard protocol is not any different based on a person's race, ethnicity, and gender, because we want to make sure that we're removing implicit bias. Unless there is a protocol that is specifically done based on research, that we have to, identify a different line of care because we know genetically we cannot do some things without harming the patient.
Thank you. The next question is, what are some institutional or systemic approaches that can help reduce bias and improve maternal health equity?
What are some institutional? Well, I think again, this kind of goes with the previous question that was asked, and that again goes with reviewing some of the policies and practices. But even with the institutional, we need to look at who's making the policies and the standardized protocols. Does it look like the community that it represents? And if not, we need to include those members of the community first off, and we also need to include professionals that look like the community that it's serving, because people again, that goes into our cultural attunement and cultural competency. We need to ensure that we're meeting all of the best practices, but at the same token, we need to have those best practices discussed with the people that it's going to affect.
Thank you. The next question is, how do we access that implicit bias test?
Okay, so on Stanford's Stanford and Harvard's website, you can access it there, or you can just type it in Google and put in the title, and it should come up. I hope I answered the question.
Thank you so much for that. We will also have the video recorded, so if anyone would like to see anything else or rewatch it, we will have it recorded, and it'll be posted to our website and also our YouTube page. We would like to thank everyone